Hello, my name is Daniel Eichorn, and I will be presenting to you a study regarding the incidence of and risk factors associated with focal fold hemorrhage following type 1 thyroplasty with Gore-Tex implant. The authors have nothing to disclose. Type 1 thyroplasty is a safe outpatient procedure. Life-threatening complications are uncommon, but others can occur, such as soft tissue reactions, edema, hemorrhage, and shifting or extrusion of implant. Hemorrhage rate in type 1 thyroplasty is unknown, and the causes of vocal fold hemorrhage remain unclear. Former studies performed on other types of laryngeal surgeries suggest that patients receiving anticoagulation or antiplatelet therapy were not at an increased risk of hemorrhage, and some of these studies even suggested no need to stop anticoagulation prior to surgery. The objectives of our study were twofold. One, to determine the rate of vocal fold hemorrhage following type 1 thyroplasty performed with Gore-Tex. And two, we aimed to define whether age, comorbidities, anticoagulation therapy, and presence of vocal fold ectasia are associated with increased risk of hemorrhage. Medical charts of 93 patients who underwent type 1 thyroplasty with Gore-Tex, either primary or revision surgeries, between the years 2013 and 2019 were reviewed retrospectively. 86 patients were included in the study. Data gathered included the age at time of surgery, sex, unilateral or bilateral surgery, preoperative antiplatelet or anticoagulation therapies, medical comorbidities with specific attention to underlying pulmonary disease, preoperative American Society of Anesthesiology score, other otolaryngologic diagnoses, preoperative video stroboscopy, and postoperative vocal fold hemorrhage and timing of hemorrhage resolution. We liberally defined hemorrhage as any submucosal erythema on the vocal fold surface, even when isolated to the superior surface. At our center, patients are evaluated as outpatients from 2 weeks up to 3 months prior to thyroplasty. Patients taking anticoagulation therapy are instructed to discontinue under medical supervision less than 1 week prior or 2 weeks prior if aspirin. All procedures were performed under local anesthesia with sedation. Flexible laryngoscopy was performed at the end of every case, and patients are scheduled to follow up at 1 day, 1 week, and 4 to 6 weeks after surgery. Upon discharge home, they are advised on temporary lifestyle modifications such as voice rest for the first 24 hours, avoid heavy lifting and physical activity, and sleeping with the head of the bed elevated 30 degrees. We divided patients into 2 groups depending on whether they had postoperative vocal fold hemorrhage or not. This hemorrhage was identified on the postoperative day 1 follow-up visit at the outpatient office. Statistical analyses were completed using chi-squared and student's t-test. The rates of ectasia or varices identified on preoperative video stroboscopy were calculated and analyzed using each vocal fold side as a single surgery. So for patients undergoing bilateral surgery, that would count as 2 sides. We also calculated these numbers by patient. P-values were considered statistically significant at the p is less than 0.05 level. This table here shows our demographic and incidence data for our hemorrhage and no hemorrhage groups. In regards to sex, age, mean number of medical comorbidities, mean ASA score, and underlying pulmonary disease, there were no statistically significant differences between groups. Our incidence of postoperative vocal fold hemorrhage was 26%, or 22 out of 86 patients. The table on the left shows our anticoagulation data and its association with postoperative vocal fold hemorrhage. Among the 22 patients with postoperative vocal fold hemorrhage, 5 were found to have been receiving anticoagulation or antiplatelet therapy. This rate was statistically significantly higher than the rate of anticoagulation or antiplatelet therapy among patients with no postoperative vocal fold hemorrhage. On the right, this table demonstrates our ectasia and varices data and its association with postoperative vocal fold hemorrhage. This table breaks the data down according to number of surgical sides. These 60 unilateral and 26 bilateral surgeries combined for a total of 112 surgical sides. 25 of those sides were found to have postoperative vocal fold hemorrhage on post-op day 1. Of those 25 sides, 80% were found to have ectasia or varices on preoperative exam. We found that patients with postoperative vocal fold hemorrhage had a statistically significantly higher rate of ectasia or varices on pre-op exam compared to patients with no postoperative vocal fold hemorrhage. This table here shows our ectasia and varices data when calculated by patient. Among the 22 patients with postoperative vocal fold hemorrhage, we found ectasia or varices on the vocal fold preoperatively in 17 patients. This made for a rate of 77%, which is similar to the rate of ectasia or varices when calculated by surgical side. We found that patients with postoperative vocal fold hemorrhage had a statistically significantly higher rate of ectasia or varices when compared to patients with no postoperative vocal fold hemorrhage. It's also important to notice that of the 22 patients with post-op vocal fold hemorrhage, 17 were found on postoperative day 1. 9 of those 17 patients had resolution of their hemorrhage within 1 week. Our study found an incidence of postoperative vocal fold hemorrhage of 22.3%. This number was calculated using the total number of surgical sides or procedures. The incidence remained similar when calculated with number of patients. There we found a 26% incidence. The majority of postoperative vocal fold hemorrhages were identified on postoperative day 1. These numbers were similar regardless of how they were calculated. It is important to note that of the 17 patients in whom hemorrhage was identified on post-op day 1, 9 had full resolution by postoperative day 8. These hemorrhages would have gone unrecognized if there had been no examination on post-op day 1. Anticoagulation and antiplatelet therapies that patients were taking included a baby aspirin, enoxaparin, and warfarin. The number of patients taking each agent was not sufficient to investigate the risk of hemorrhage associated with each medication. Each of these medications listed were all recommended to be stopped in accordance with current standard of care, and all medications were restarted within 1 to 2 days after surgery. This is the largest study to date investigating the incidence of and risk factors associated with developing a postoperative vocal fold hemorrhage following type 1 thyroplasty. We used a very inclusive definition of hemorrhage. We found an incidence of 22.3% for vocal fold hemorrhage when calculated by number of surgical sides. We found a similar incidence when calculated by patient, 25.5%. The presence of vocal fold varices or ectasia on preoperative exam are associated with an increased risk of hemorrhage following type 1 thyroplasty. Additionally, preoperative use of antiplatelet or anticoagulation therapy are associated with an increased risk of hemorrhage as well. Further studies are needed to confirm or refute these findings. Thank you for your time.